When I was at primary school in the mid-2000s, the concept of health literacy was still growing and not an integral part of the Australian and state and territory school curriculums as it is today. As Nutbeam said in 2006, health literacy is a relatively new concept in health promotion, but it plays an important role in health education. There is no one straightforward definition of what health literacy actually is. The prototypical model, however, is largely based upon Nutbeam's definition. Nutbeam has been credited by McGuaig et al. As challenging the narrow definitions of health literacy by drawing on studies of others to design a ternary-levelled framework of health literacy. Nutbeam used Freebody and Luke's work in educational literacy, whereby they stated types of literacy are not so much used as ways to measure achievements in reading and writing, but rather used as tools in identifying what it is exactly that literacy enables us to do. The framework of Nutbeams contains 3 levels of health literacy and their corresponding goals. Level 1 is called functional health literacy. This is where information is communicated about health risks and the utilisation of health services. The information is very basic and covers areas such as hygiene, nutrition, safety, drugs, relationships, sexuality, and parenthood. St. Leger states that it is reasonable to expect all schools to be working at a Level 1 standard. An example of this is how developed and developing countries are both able to provide information about what constitutes as a balanced diet. This falls under the food and nutrition area of Level 1. Level 2 is called interactive health literacy. This is where the information from Level 1 is further analysed, and opportunities are created to develop specific skills. These could include problem solving, food preparation, hygiene, and communication. Level 3 is called critical health literacy. This is where learning opportunities are created in the classroom and community to address social and economic impacts of health, inequity, policy development, and how to affect or create change. St. Leger believes that achieving Level 3 is beyond the current capacity of most schools. He proposes 3 challenges that need to be addressed in order for this level to be achieved. Elmore, mentioned in St. Leger's article, argues that there are 3 substantial changes needed to be embraced by schools to achieve critical literacy. Green has a different 3-dimensional model, which can be adapted to health literacies. As written in Renwick, each dimension has a particular focus for literacy work to be undertaken. However, these are interrelated and mutually germane, rather than being separate or isolated considerations. Health literacy is important across all year levels of the Foundation to Year 10 curriculum. Under the Australian curriculum, health literacy is defined as the ability to selectively access and critically analyse information, navigate community services and resources, and take action to promote personal health and the health of others. It is one of the 5 rationales of the health and physical education curriculum. The Foundation to Year 10 curriculum contains 12 focus areas, which provide the context through which content descriptions and achievement standards are taught and assessed. I will now be analysing health literacy, specifically with regards to the food and nutrition focus areas and the benefits and limitations of this. Duchesne and McMaw wrote that very poor nutrition affects brain growth, physical growth, protection against disease, and cognitive functions such as long-term memory, and that inadequate nutrition can also result in lethargy, which affects motivation. The human body needs a combination of nutrients to supply it with enough energy to function effectively. The Australian Guide to Healthy Eating provides clear recommendations of types of food that should be eaten to meet nutritional requirements. Activities in health can be based around healthy eating to educate students on what constitutes as healthy eating. These can include matching images of food to their corresponding food groups, comparing students' school lunches throughout the week, and using crossword puzzles to connect the names of fruits and vegetables to their descriptions. This gets students to participate in interactive health literacy, which is Level 2 in Nutbeam's framework. It may seem basic, but I've found some people are unaware of the names of typical fruits and vegetables. I once went to my local supermarket to buy a yellow squash, and the young teenager at the register had never seen one before. Families who live in poverty and low socioeconomic areas sometimes have no choice but to feed their children unhealthy meals. This means that, like the teenager I encountered, some people are unable to identify healthy foods. Berkman et al. Demonstrated the critical relationships between low literacy, health status, and health outcomes. Parker also made the connection that low literacy in a population is indirectly and directly associated with a range of poor health conditions. Nutbeam in 2008 further emphasized these 2 points by stating low literacy is often linked to poor socioeconomic circumstances, and that this in turn is associated with adverse effects on health that are independent of other risk factors. Children growing up in poverty are less likely to have good quality meals and medical care, wrote Connell. A benefit of including food and nutrition-based health literacy in the classroom is that students who live in poverty and low socioeconomic areas have the opportunity to be informed about healthy choices when they may not have otherwise. A limitation of this, though, is how can these families combat the antecedents and consequences of health literacy they are faced with. By 2025, if trends continue, it is predicted that 80% of Australian adults and 30% of Australian children will be overweight. In 2013, 67% of adults were overweight or obese. On hearing statistics like that, a sense of fear is installed. Childhood obesity is labelled as a crisis, when according to Compos et al., the obesity-driven health crisis is being driven more by cultural and political factors than by any threat increasing body weight may pose to public health. The benefit of health literacy, says Renwick, is that it places a key issue on the education agenda at the time of health scares, such as above. Tones in 2002, though, labelled health literacy as merely new wine in old bottles. It is essentially reinterpreting concepts central to the ideological theory and practice of health promotion. Many other scholars disagree, and even the World Health Organization has listed health literacy as a priority on its 2030 agenda. Nutbeam contends that if achieving health literacy is a goal of the World Health Organization, some widening of content and methods will need to occur. It involves more than just the transmission of health information.